Thank you, Ralph, for that. Thank you for coming, everyone. And I'm going to do my best to put across the message of sickle cell disease and how it affects children in schools. Okay. Right, the aim of the session today is to discuss what actually sickle cell disease is and how it's caused. And the objectives of this session is how we're going to discuss how to help prevent a sickle cell pain crisis, what practical measures you can do to support a child in school, and lastly, when to seek medical assistance. Okay, everyone, sickle cell disease is an inherited condition whereby an individual has two abnormal hemoglobin genes, one or both of them being sickle hemoglobin. I'd like you to have a really good look at this picture because this actually typifies what happens inside of the blood vessel of somebody having a sickle cell, who has sickle cell disease, and what causes the sickle cell pain crisis. Okay. Right, so we'll just sort of have a look at blood composition. Now, the sickle cell problem happens with the, it's affected, the red blood cell is affected. The quality, structure and function of the red blood cell is affected. Okay, so red blood cells, the red colour is the pigment in the red blood cells is called hemoglobin, and that's the oxygen carrying sort of chemical compound, sorry, in the blood. Okay, so that's what keeps us healthy and well. When the blood's circulating properly, we're getting oxygen where we need to, all around the body, that keeps us healthy and well. So the red blood cell is made up of two parts, the heme, the iron bit, and the globin, which is the protein which determines your hemoglobin type. Okay, so we're looking at the picture at the very top one. White blood cells there as well. They're less in number, but they do a good job helping to fight infection. We've got platelets there that are necessary for clotting and controlling bleeding, and the plasma, everything's contained in the plasma, which is the water that constitutes of the blood, and it's 90% water. Now, if we can look at the hemoglobin molecule at the bottom there, in sickle cell disease, there's a mutation in the hemoglobin molecule. So that's what the problem is. There's a mutation within the actual molecule that causes all of the problems with the structure and the function of the shape and quality of the red blood cells. I hope I've explained that well. Next slide. So we can see two pictures here. Okay, so what actually happens to red blood cells in sickle cell disease? Right, so if you can have a look at the normal cell there, it's sort of donut shape and it's very flexible, spongy, and it can squash flat. And the first picture here, it shows you how the normal red blood cells fit through that bottle shaped thing, which represents the blood vessel. So we don't have any problems with people without sickle cell, who don't have sickle cell. So the red blood cells go straight through, carries the oxygen where it needs to be, helps repair the body and keeps everybody healthy and well. Okay, now if we look on the other side, the actual sickle cell is a crescent shape, very unusual shape. It's brittle in contrast to the normal. It's brittle and doesn't bend really easily. So something like this is expelled from the body very quickly. Between 15 and 30 days, the sickle red blood cell is destroyed, sort of broken down and removed out of the body through the liver. Okay, normal red blood cells take 120 days to sort of live in the person's system, and it sort of does all the repair work that it's necessary to do. So someone with sickle cell disease, you can see in the picture down there at the bottom, that shows that the odd sickle shape causes, like, it's all damage, destruction, and red blood cells can't go through sort of like a traffic jam. It doesn't go through, so it doesn't carry the oxygen, and that's actually what happens inside the body to cause the sickle cell pain episode that they have, the pain and discomfort that you're going to hear me talk about later on. Okay, so we refer to it as sickle cell pain crisis. So once again, the quality of the red blood cell is the structure and function. It's a quality of the red blood cell that is a problem for children and adults with sickle cell disease. Okay, if we look at who carries what people sort of normally suffer from sickle cell disease, we have the highest prevalence in African people and people of African Caribbean origins, but also it's carried in people from the Middle East, India and Eastern Mediterranean. Okay, so to explain even more, the carrier frequencies, we've got 1 in 4, typically 1 in 4 West Africans are carriers of the sickle cell gene. We've got 1 in 10 African Caribbean people who have who are carriers. We've got 1 in 20 Asians, and between 1 in 50 and 1 in 100 Mediterranean and people from the Middle East who are carriers of the sickle cell gene. Okay, so the reason why they're carriers, if you can see the map here, just to basically to sort of show you the areas that are high risk of malaria. You see that's half the world there, but all those areas are the people that I've just spoken about who are carriers of the sickle cell gene. Now this came about because it was sort of being a carrier is a protective mechanism from sort of succumbing to malarial infection. Okay, so they had a better chance of survival if they were carriers of the sickle cell gene. Okay. All right then, so for someone to have sickle cell disease, the full-blown disease, both parents have to be silent carriers, if you'd like. The carriers of the sickle cell gene, but usually they're not affected by being a carrier. They're not unhealthy. Sometimes people don't even know they're carrying the gene unless they're tested and they have a blood test. So 2 healthy carriers, every time they have a baby together, the inheritance implications is it's a 25% chance of having a child that doesn't carry any unusual genes, so they have normal hemoglobin. Okay, 25% chance of a child that will inherit the sickle cell disease. Okay, and then there's a 50% chance of the children being carriers of the sickle cell gene. So every time they have a child together, this is the scenario that happens each and every time. Some parents I've come across in my years of doing sickle cell and counselling, they think if they have one child that's got sickle cell, then they have 3 other chances of not having a child with sickle cell, but unfortunately that doesn't occur, that doesn't happen. So some parents may end up with 3 children with sickle cell, one after the other. So it's really important that they're aware of the inheritance implications for each and every child that they have. Okay, so we have a national screening programme. I don't know whether everyone's aware of that, but the national screening programme's been running for about 20 odd years, but in the early days, they only sort of tested women of the ethnic origins that I spoke about earlier. But that now has, that still continues, but there's a universal screening program going on. That means every pregnant lady who books in a maternity unit has a blood test, and she's also screened for sickle cell and thalassaemia, amongst many other things. So it's like a universal screening now where every pregnant woman gets tested antenatally. If we find that the lady is a carrier of the sickle cell gene or any other variants, we will invite the biological father of the baby in and also test him, and then we can see whether the child may be at risk, as I've just discussed in the previous slide. So that's what we normally do to sort of make parents aware that there's a chance that they could have a child that's affected if both parents are carriers of the disease. Now, of course, it's a 1 in 2 chance if there's a full-blown sickle parent and a carrier, so the incidence is higher. Antenatally, the midwife or the haemoglobinopathy counsellor, they would sort of offer prenatal diagnosis, but sort of explain that to parents. They don't always go for that because there's a very small risk of the baby termination, miscarriage, not termination, sorry. Okay, so that's what's offered antenatally. And also the screening program, it takes the screening for newborn babies too. Within 5 days of being born, the child has what we call a blood spot test. Some people may know it as heel prick test, and that's sent away to the labs, and they're looking for the carriers or any child affected by sickle cell disease. Once we find out that the child is a carrier, then the health visitor will go and see and explain the inheritance implications to parents, just as they did when antenatally. But if the child has full-blown sickle cell disease, then parents will be contacted by a specialist nurse, such as myself, or the clinical nurse specialist from the hospital, who will sort of give them advice, education around what's going to happen next and how we plan to sort of support them in looking after their child. Also, we discuss medication that the child needs to be started on, and actually what happens in the first and subsequent appointments with the haematology consultant that child will be seen going forward after that. Okay, so there's the birth ratio is about 1 in 2,000 children are born with sickle cell disease per year in England, not the UK. I've only got figures for England. Okay, as you can see, there's lots of different types, 6 types of sickle cell anemia disease, but the sickle cell anemia that I've highlighted there, the hemoglobin SS, is the most severe of all of them, and the child or the adult tends to have a lot more sickle pain crisis and suffer quite a lot more problems. Saying that, all of the sickle cell diseases come with their different problems, and no 2 individuals with sickle cell anemia will have the same symptoms. They come with a collection of different symptoms, affect people in different ways. Okay, so it's not a sort of one size fits all thing. They can suffer different problems, each and every one of them. But again, the hemoglobin SS is the worst of all of them, just to point that out. Okay, so symptoms of sickle cell disease. Now, sickle cell disease is a collection of symptoms, yes, but a lot of the time we refer to it as anemia because people understand anemia and understand when you have anemia, you're not feeling right, you feel a bit lethargic and weak. If you're somebody that doesn't have sickle cell and you're a bit anemic, you go to your GP. The GP will sort of prescribe iron medication. After 3 months, you're fine and well. Somebody with sickle cell, it's a lifelong, continuous, chronic anemia they have, and they have to deal with it lifelong. So it's a chronic anemia, lifelong anemia for those people. Okay, so with the anemia, the incidence of catching infection is really high. The anemia makes the immunity quite poor. You can remember the red blood cells that break down and come out of the system very quickly. They're not doing much to support, you know, the immunity. So this is why the children, as soon as we know that they have sickle cell disease, medication, penicillin, they're put on penicillin, low dosage penicillin to help boost their immunity. So it's really important that parents are made aware that this is an ongoing thing. They need to have it twice a day, as long as a consultant hematologist tells them that they need to have it. So it's not really optional, it's something that's very necessary. And okay, so we've spoken about the pain crisis. Remember the picture with the odd-shaped sickle cell. So when they do get stuck within the blood vessels, that's wherever they get stuck, or you know, there's a backup of sickle cell, then oxygen's not getting through into the right place, and it's causing pain, excruciating pain most times, and discomfort, and that will affect the person psychologically when that keeps happening all the time. So as you can see in the picture here, we've talked about the anemia. This person with sickle cell will be fatigued most of the time. They may have, because of the sort of destruction of the red blood cells coming out into the liver, jaundice, yellow eyes, yellow tinge on their skins possibly. They may be breathless, they may have back pain, because remember the sickle cells go everywhere, and they can experience sickle cell pain crisis anywhere in the body where the blood goes. Okay, so they can have hand swelling, arm and leg pain, joint pain, foot swelling. So it actually reaches from head to foot everywhere, and that is a horrible situation to be in most of the time for people with sickle cell anemia. Okay, so we talk about sort of sickle cell pain crisis trigger factors. These are the things that cause sort of bring on the sickle cell crisis pain, and things as simple as sort of extremes of temperature. If someone in the freezing conditions, either too hot or too cold, can sort of trigger the sickle cell vaso-occlusive crisis that we can see down there in the picture. Something as simple as extremes of temperature, extremes of weather. So it's really important that people with sickle cell dress accordingly. Parents are usually educated and made aware that children need to be kept warm in cold, inclement weather, and you know, sort of have in hot weather, have lots to drink, and you know, there's a balance that we need to maintain to keep these children, school children, healthy. Okay, so I'll talk a bit more about that after the break, how we can do that in schools. Okay, so at least we're aware extremes of temperature, too hot or too cold, can cause a trigger off the sickle crisis. Infection, we've discussed already. It's really important because of the low immunity that we sort of maintain healthy, take medication and sort of fight infection. Okay, dehydration, we'll discuss that further down in the presentation. It's really important for children with sickle cell disease to be kept, and adults to be kept well hydrated. We sort of ask them to drink between 2.5 litres, you know, 2.5 litres per day to help sort of get rid of the sickle cells in the body, so they have at least lesser chance of getting infection. Okay, so another trigger factor is something as simple as exams, school exams. We tend to see a lot of children, you know, with sickle pain around exam time, especially university students. Sorry, I can hear some. Okay, stress in the way of extreme sports and training. It can because there's an increase in physiological demand, that can also trigger a sickle cell crisis. We've got pregnancy as well. It's a very risky time. No school child should be in that position, but pregnancy, just to sort of point out what are the sort of the extreme trigger factors, and hypoxia, which is a lack of oxygen in the blood. Okay, so those are the trigger factors we tend to sort of highlight and try and avoid for people with sickle cell disease. Okay, we look at this jolly picture here, parts of the body that are affected by sickle cell disease. So as I said before, sickle cell disease is a collection of symptoms, okay? So we refer to it as a multi-system problem or multi-systemic problems that can happen in the body. Right, let's start off with the eyes. It's really important that children attend their hospital appointments to see the haematology consultant and report any sort of abnormalities. We encourage parents to sort of let us know what's going on when they're at home, if they're sort of any sort of problems with the eyes, you know, visual disturbance, anything like that. It's really important because, as we say, sickling can happen everywhere, and if it happens at the back of the eye, there is a chance the child can lose the sight. So it's very important, and if then they might need to have sort of top-up transfusions or you know, to be referred to ophthalmology clinics and all sorts of things. So it's really, really important that parents communicate well and not hold anything back from their haematology consultant, and that needs to be encouraged. And if the schools find any, you know, sort of visual disturbances, discuss it with parents, you know, if the child's not seeing the board properly or whatever. Yeah, so the parent then can sort of discuss that with the haematology consultant. Okay, so gums can be affected by sickling as well. So affect the teeth, and the teeth might protrude if they're not sort of growing normally because the gums are sickling going on in the gums. Things like this, you know, need to be also reported if they're getting pain in the mouth when they come to clinic, and even before let their GP know. All these things that sort of unusual type things to do with pain need to be reported, so the doctors can then sufficiently deal with the problem. Okay, so gallbladder, gallstones. Children and adults can get gallstones, believe it or not. In the old days, because I'm old, they used to say you're fair, fat and 40 to get gallstones, but that's not the case for people with children with sickle cell, because there's such a sort of high amount of pigment, bilirubin it's called, the bile sort of pigment, that sort of gives off a yellowish colour. And later on in the presentation, I'll show you sort of a picture of a child with jaundice around the eyes. So, you know, having gallstones at a very young age like that, it's awful. It's bad enough when you're an adult, but these are the things that can happen because of what's going on in the body inside of someone with sickle cell disease. The kidney can be affected also with any sort of sickling, and that, you know, can bring because children can't concentrate urine, they tend to use the toilet a lot, coupled with having to drink a lot to sort of help them. It's sort of not a nice situation for them if that happens. A lot of the children can be known to bedwet and nighttime bedwetting. It's important, especially boys. It's important for that to be reported also to the haematology consultant, because they're interested in all the things that aren't going well, going well as well, but aren't going well, so they can have a look and see how they can help that child overcome it. So rather than a sort of parent should be encouraged to sort of not hold anything back, not feel ashamed, because it's really important. They need their child to achieve like everybody else, but if they've got a lot of problems and they're not dealt with, it will affect their affect them psychologically. Okay, so we can get sickling in the lung, which is really awful. We call it sickle chest, and basically the child or the adult's not able to breathe if there's sickling going on. So it's a real emergency situation, and the child would need to go to hospital because they're not breathing well. Okay, and okay, so spleen also, we have spleen problems, little organ in the sort of stomach region, that it can become blocked with sickle cells, just like you saw in the picture in the slide a couple of slides ago. So the small spleen can get engorged with lots of damaged red blood cells, sickle cells, and expand the spleen. So that means that if that happens, if we get a lot of sickling in the spleen, the stomach distends and the child can collapse. The hemoglobin will be very low, so the blood level will be very low, and that sort of brings on a collapse or something like that. So something similar. So it's really, really a dangerous situation. Okay, so the brain. That can be affected by sickling also, and later on in the presentation I'll show you a picture of how it can affect the brain. So the sickling can cause narrowing in the vessels of the brain, and that can have an impact. That can lead to stroke. Yeah, at any age really. So from the age of 2 to 16 years, children with the hemoglobin SS, sickle cell anemia, they receive yearly what we call transcranial Doppler, which is like an ultrasound, that something similar to what the pregnant ladies would get to look at the baby. They have that both sides of the head, and every year in the hospital, so the doctors can keep an eye on if there's any sort of narrowing of the vessels, which may lead to a high incidence of stroke. If they find that there's any sort of narrowing in the vessels there, then they put the children on different treatment, maybe blood transfusions, maybe different medications. But it's important that, you know, the doctors are aware, and children do turn up for these appointments. Whether it's school day or not, they need to come and sort of return to school after, because it's really important. Okay, I'll talk more about stroke risk later on in the presentation. Okay, believe it or not, bones are affected by sickling as well. We can get bone deterioration with excessive sickling in one place, or different parts of the bone, and that will affect the child's mobility and, you know, how they get on really, and how they walk around, and, you know, and it's a significant thing really, because it can destroy their confidence. So, you know, so these things need to be sort of discussed when the children are seeing the consultant or with the sickle cell specialist nurse. Okay, right, so the next bit is hard to believe, but this is what happens in little boys at any age, men also. They can have sickling in the penis, which sort of means that there's unwanted painful erections that last for a long time. But what we say, anything after 2 hours, more than 2 hours, they need to go to the accident and emergency department to have medical treatment, because it's something that can cause them irreparable damage, and if not dealt with, and affect the structure and function of the penis later on in life. So it's really important. Yes, so children with sickle cell disease, they tend to, their pubertal growth is a little bit more delayed than their peers, say, and it's more sort of noticeable when they hit year 6, year 7. They find that all of their peer group have grown a bit, and they haven't, and, you know, that's a really big thing. When the children do come for their hematology appointment, one of the important things is to do their height, weight, and sort of monitor their growth as well. If there's any sort of abnormality with that, the consultant hematologist will refer them to endocrinology clinic, where the endocrine doctors, the growth and development doctors, will sort of give them sort of medication to help them grow, you know, sort of catch up, or just keep an eye on them, sort of look into their diet, making sure they're eating well. So these are the sort of things that we've got to sort of realise what is going on with a child with sickle cell. Right, so the most important thing really, education. Put there, education is the key. education in clinic when they come to the clinics to see the hospital consultant haematologist. It's at that point that the children sort of need to learn about, have a little bit of education, age appropriate education on what they have, what condition they have, and how to, what they have to do to help themselves not be poorly and ill. So education starts as well as at home. We sort of encourage and support parents with education with their children at home. A lot of that is done with the community nurses and hospital nurses. It's really important because the parents, there's only so much they can do, and there's only so much when the children grow, so much they listen to their parents who've been sort of going on about the same thing for a long time. Make sure you wear your coat, make sure you have your medicines, all things like that. So the older they get, they tend to switch off, and this is when we sort of are around to sort of support parents with the education with their children by giving them sort of age appropriate literature to read. Okay, and answering any question that they have. Okay, the most important thing in the education side is to encourage parents or schools to, sort of bring children to hospital when they sort of first see there's a problem, rather than trying to sort of deal with it themselves. Some parents can keep children at home for about 5 days and hoping that the temperature will go down, and by the time they get to hospital they're very, very ill. So the doctors, the haematologists, like early presentation to hospital, so if there's a problem they can look into it and get it sorted, so the child can not have to go through a lot of debilitating sort of problems. So early presentation to hospital, if you're in doubt, for them to get a medical assessment is the best. Okay, going back to prevention now. As I said before, when the blood spot test has been made available, and we know that the child has sickle cell disease, as soon as the sort of before the child starts clinic, or just as the child starts for the first appointment to see the consultant, started on penicillin prophylaxis, penicillin V, which is sort of a low dose penicillin to help to boost the immunity. Okay, it's really important. Okay, the child should have, the baby or child should have their regular routine vaccinations, plus additional vaccinations also. We have something called a pneumococcal vaccine that children with sickle cell disease need to have every 5 years religiously. And the yearly flu vaccine, that's important, extra hepatitis B, meningitis vaccinations, and also if they're taken abroad on family holidays, malaria, travel medication, as well as sort of presenting them to the GPs so they can have any sort of travel vaccinations that's necessary for that country. Also, parents need to make the haematology consultant aware that they're taking the child abroad, so the child blood can be checked and everything's in place for that child, and the child's well enough to travel. So it's really important. So the preventative side and education is really the key in circumstances. Okay, so as we say again, so as soon as we know the child has got sickle cell disease, penicillin's commenced. Okay, and we're just showing you folic acid also is a vitamin, and it's alongside penicillin. The folic acid is once a day, and it helps to sort of strengthen the red blood cells there. See the muscles. Okay, so it's really important they take 2 lots of medicines as prescribed. Children do get used to it, but they do complain of the horrible taste of penicillin as soon as they realise, and they tend to ask for tablets because they know the taste won't stay in their mouth. Okay, so as soon as they know how to swallow well, they are on a tablet, penicillin tablet. Right, okay, so Ralph, I think, Ralph, okay, sorry.
Hey.
Hi, I can't remember how are we doing for time?
We're a little bit behind time.
Okay, so we'll do this after, we'll look at what it looks like after the comfort break.
Yeah, that works. So
all right.
We'll do about 2 or 3 minutes and then come back, yeah?
Yeah. Right, okay, I'm gonna crack on then. Okay, so what does sickle cell disease complications look like? I've explained quite a lot of what's going on now, so I'm just going to run through a few slides that you can see. Okay, so jaundice, this would be something that the child might look like in school. It's important, you sort of are aware of what's going on now with the sickle cell child. Okay, also there's something called dactylitis where they have sort of children, the young ones, 0 to 5, may present with sort of tight swollen fingers there. They need to go to hospital for that. Okay, parvovirus, right, the slap cheek syndrome is an important thing. If a child with sickle cell has that, it can stop blood production from the bone marrow and cause like a huge problem for them. Okay, and if any child in school has the sort of slap cheek syndrome, then you need to sort of inform the parent with the sickle cell child that somebody in schools had it, so they can sort of keep an eye on their child, and if anything sort of happens, then they can get them straight to hospital, knowing that there's been slap cheek syndrome in school. Right, okay, so these are the sort of disease complications of the bones. Sickling can happen in the large bones there. There's a picture at the bottom there that shows a destroyed cartilage from what happens sickling in the bones, okay, in the joints. Okay, so bacterial infection is the children, why we need sort of the penicillin is because children are 400 times greater catching severe infections because of the low immunity. So pneumococcal sepsis infection is a real big, it's actually a killer for children with sickle cell disease. So it's important to keep infection at bay. Okay, so remember I talked about the spleen swelling and sort of enlarging with sickle cells. That sort of picture there on the left-hand side. Spleen should be sort of not sort of below the ribs. Doctors teach parents how to feel for spleen size when they come to clinic, so they can keep an eye on whether this spleen is filling with unwanted sickle cells. Okay. Okay, so you come across children. Remember I said that they had scans of their head, those with sickle cell anemia. Okay, so some children, it's really important for schools to sort of keep an eye on that. If a child sort of changes the behaviour or the concentration level, sort of very unusual to what they are normally like, sort of sudden deterioration in the quality of their schoolwork. This is like a slow, insidious thing that happens. It can happen, say, over a week, and they're suffering from a silent stroke there. So if you just look at the picture there on the left, it shows where there's sort of, impaired blood supply and stroke there. Okay, so obvious strokes, so the strokes that person would sort of collapse in front of you, and you look at the fast sort of facial weakness, can the person raise their arms, things like that, and everybody's sort of aware of that. So basically that would be the time to dial for emergency, the ambulance. Okay, so just quickly going through good practice tips for schools. Okay, right. Hydration, remember we need to kick infection out. We just want to sort of make sure the child's well hydrated, has supply of water with them in their bag or on the table. There should be no restrictions really for a child with sickle cell. As I said, 2 to 3 litres per day, and sort of ensure that they aren't restricted from drinking fluids. Okay, so if they drink a lot, they're going to need a toilet pass to go to the toilets, just to avoid them being embarrassed and having to put their hand up all the time that they sort of need to go to the toilet. So once you're aware they've got sickle cell and they're drinking plenty, they need like a toilet pass to sort of sneak out of class very quickly and come back. Okay, so you can see temperature. Remember we said the trigger factors, the extremes of temperature, too hot, too cold. Okay, so it's a good practice there not to overheat the classroom, maintain good ventilation, avoid drafts. If the child needs to wear extra clothing, if they're sent to school with extra clothing, there's a reason, weather's cold, allow them to sort of take layers off, put layers on as and when they need to. It's not that they're being awkward, it's because they're feeling chilly and they're trying to avoid sickle pain crisis. Okay, so in snowy sort of weathers, if the child says they're really cold, they're too cold to sort of for the weather that's outside, whether sleet, snow, whatever, it's a good idea to sort of keep them inside and sort of make supervisory staff aware. Okay, even physical exercise, extreme strenuous exercise, it can lead to sickle cell crisis. So we encourage moderate exercise, listen to the parent and the pupil regards to their tolerance level, exercise tolerance levels. If the child says they're sort of tired after doing games or PE, whatever, for how long, then please sort of give them time to rest or excuse them. So they're not feeling excluded, you know, because they have anemia, and although it doesn't show all the time, it can affect them. They tire much easier than the other children without sickle cell. Okay. Swimming also is really important that prior to child with sickle cell going swimming, the water temperature is sort of very warm, so that they don't have extremes of temperature coming out of a very cold pool. They need to be dried sort of at poolside, not sort of left to be wet and walking around, because that can cause them more sort of problems with sickling. Okay, and if it's not a sort of designated sort of pool that they go to for school, it's good to sort of liaise with the local leisure centres, ask them to sort of increase the sort of temperature because you have a child with sickle cell disease, and might be a problematic thing if they go freezing cold water. Okay. All right, other points to consider. A lot of the children complain about having to bring lots of books around school in their rucksacks and all sorts of things. Now this is exerting stress. It's like exercise, isn't it? Weight bearing. So you know that can bring on a sickle cell crisis also. So if the schools can provide a sort of lockers or some way for the child to sort of put their books, heavy bags, to minimise all the stress and effort that's needed, because they'll end up being very exhausted and can bring on a sickle crisis pain also. And if they have to sort of go, if they're having sort of any bone pain, sort of to use a lift, have a lift key, something like that. It would be really great things to consider. Okay, the child's emotional well-being is really important. A lot of the times they don't look ill until they're really unwell. A lot of the children will say, oh, I've told the teacher, and the teacher says, oh, you look all right to me, you know, go along, whatever. But yes, a lot of the times, because of like skin colour, they don't look ill. Possibly only if they have jaundice and something, yellow eyes, and probably somebody would say, oh, that child's not very ill, but they don't really notice. But they notice the children need a lot of support because they don't really know much about the condition, all they know is they have a lot of pain, they've got to take medication, parents are forcing them to keep warm. There's a lot of things to take on board, and it can affect their mood and the mindset. Okay, what we encourage children to do is to, schools to do is to have a designated person that child can talk to if they need to, any sort of support staff, any sort of school counsellors if they're there, or school nurses if they're in house. Okay, any sort of serious concerns, then you need to be speaking to the healthcare team, or your specialist nurse or doctor or psychologist, so we can give support to the children. Okay. Right, so same again for exams, we need support with education and learning. Some children have EHCPs, the educational healthcare plans, if they need it. Sort of extra time's needed sometimes in exams, because remember, exams bring on the stress and then the sickle crisis. So sort of small provision for extra time or rest breaks would be good. And the sort of extra time and sort of communicate with parents well. We can't sort of stress that enough. Some parents don't communicate well with the schools because they feel that it's going to let their child down educationally, but it'd be good to let them know that you're a listening ear. If there's anything that's going to affect the child in school, it's important that they talk to you about it rather than hiding it away. Okay, so just to say that, children with sickle cell disease, sometimes when they have the sickle pain crisis, if they're not admitted to hospital, they're sort of poorly at home, but they, it may take 2 or 3 days off school because of the pain. If the pain's sort of excruciating, they go into hospital and they may need blood transfusions, different sort of investigations, and there's a lot going on behind the scenes a lot of the time. But we encourage parents to talk to teachers to let them know the child's been in hospital. They don't tend to, a lot of them sort of hide it away because they think it's going to make things worse for the children. But if the communication sort of conversation is sort of ongoing, then the school's aware, oh, child's been in for last week and he's been in the hospital for 3 days, then the child will have sort of more time to convalesce and then sort of feel not rushed back to school and things like that, because parents haven't told schools that the child's been in hospital. Things like that. Okay. Right, so each child should have an individual healthcare plan. Your specialist nurse, community nurse, hospital nurse, school nurse, they're all sort of involved in doing things like this for each child with sickle cell disease. And there is, I'm sort of going a bit quicker now. So this care plan, the individual healthcare plan, will sort of list things that you need to watch out for, like the things I've discussed there, and key contacts for that child in emergencies. Okay, and it should be reviewed annually. Okay, and there's a document that was sort of produced by Wandsworth University. There's a guide to school policy there that we've got links at the end of the presentation that you can sort of dip into to sort of help you sort of understand sickle cell a bit more. Okay, so if the child's off school for long periods of time, it'd be good to have that network with parent to see whether you can send school work home for the child, just to make them know that they're not, if they want to sort of catch up in any way, that opportunity is there for them, so they won't feel left behind when they return to school. Okay, so if the child's in pain, good for schools to have prompt recognition. Just look at the child's behaviour. They're crying or very quiet. Any changes in behaviour. Offer them sort of fluids, sort of a quarter to rest in wherever. Give medication. A lot of parents bring paracetamol and ibuprofen into school and sign the medical form to say schools can give that. It has to be prescribed. It has to have the prescription label on it, prescription from the doctor. Use distraction techniques for the children, to sort of keep an eye on them also. And if after a certain while, an hour, sort of 40 minutes to an hour, they don't get any better, then contact parents and sort of just look at things, sort of read down the care plan and just monitor them and know when to seek medical attention. Okay, so this is the last slide really. So you need to seek early, medical attention if the temperature is above 38 degrees C, excruciating pain if they're extremely breathless, complaining of chest pain, severe abdo pain, priapism, drowsiness, very drowsy, severe headache, has a fit, weakness in one or more of the limbs. So you call the ambulance, you ring 999, you ask for a paramedic ambulance, and after that then you can call the parent. Okay, so that's the end. And we've got some useful websites there for you. Any questions?
Perfect. Thank you so much, Barbara, for covering both your and Jackie's talk at short notice. It's incredibly good of you. One thing I was going to pick up on is you mentioned there with calling the ambulance. Is it a particular type, or you said a paramedic ambulance?
Yes, a paramedic ambulance, because they'll have the technicians there that can sort of administer oxygen or do any sort of necessary cannulation, sort of putting the needle in the back of the child's arm if the child needs a drip or anything like that. So, you know, they have sort of special equipment on board their ambulance, whereas if you just say, can we have an ambulance, they might just send a basic ambulance crew that don't have the skills to put the needle and put the drip up and things like that. So it's really, really important to stress, especially if the child's, you know, ill enough for you to ring them in the first place, then you need them to go straight to A&E and get the treatment they need on the way there. Oxygen is really important, as we know, with sickle cell. So they, you know, the normal ambulance crew might not have oxygen on board, so it's important for paramedic ambulance.
Barbara, someone's written in the chat, who does the care plan and where do we find it? Katie.
Right, the care plan should be done by your lovely community nurses or your hospital specialist nurses. You should have a community sickle cell and thalassaemia nurse somewhere. If not, speak to your school nurse and say, can you find who this sickle cell nurse is, the specialist nurses, you know, where we can find them, and then your nurse should be able to do your care plan for you. But they have to speak to parents in the process as well. So, okay, so there should be your specialist nurses around. Does that answer your question? Hello?
Hello. This is. I just wanted to find out. You said ask the school nurses. How would we know who the specialist nurse is for the area? I work in Harrow. Okay,
well, right. If you have a school nurse,
I am a school nurse.
You are a school nurse. Is that what you said?
Yes, I am a school nurse, but I'm not sure who the specialist person is that's allocated to Harrow.
Okay, so your child goes to one of the haematology clinics. Which hospital is it that they go to? No names, just tell me the hospital.
No, I didn't have a child that goes to, I'm just saying that because I'm a school nurse. If I get an inquiry from anyone, any of my schools, to say that they have a child with sickle cell, that they need to have access to the specialist sickle cell nurse. I don't know who that person is. So what I'm trying to say is, how would I know who the person is that will be our contact?
Okay, so what you have to do is sort of speak to the parent.
Okay.
Yeah, speak to the parent and find out exactly what disease that child has and where that child is seen.
Okay.
And then you take it from there, because then mother or whoever will know who the nurse is, or the hospital nurse. She'll know a specialist nurse. And if she speaks to the hospital nurse, sometimes, well, the hospital nurse automatically knows who the specialist nurse is, and then it's just a case of sort of asking questions. Parents have sort of a lot of the information.
Okay.
They have the letter as well. They have the letter from the consultant. They get copied into all of the letters. So that's your base really, and that's where to start from.
Okay, so that means we usually deal a lot with Northwick Park Hospital. So we'll have somebody that's a specialist in Northwick Park Hospital then.
Yes, yes.
We should,
yes, there is. There should be. So, as I said, you contact the parent.
The parents first. Okay.
Yeah, look at the hospital letter. Go and see mom or whatever. They always have a letter, and it will sort of be copied either to the specialist nurse as well, or you speak to the hospital nurse and she'll let you know, the haematology nurse.
Okay.
One big network.
Thank you.
Thank you. Any other questions?
There's been a couple of questions just around the availability of transcript of this meeting and also slides, etc. So probably early next week we'll get the recording of the session uploaded to YouTube, and at that juncture we'll send around the link to the session, the slides themselves, and I can send a transcript around if that would be useful for people. And yeah, we'll also include the links to the policy that Barbara mentioned in the talk, which is by Professor Simon Dyson at De Montfort University, which kind of lays out sort of policies for schools. And there's also a link to the West London HCC, which is the Sickle Cell Network for West London, which is hosting the session today. And there's a page there which also has some useful links around sickle cell in educational settings. Does anyone have any other questions?
There's a hand up from Winston. Lee Winston, sorry.
Yeah, Winston Lee. Yeah.
Oh, Winston Lee, sorry.
Not a problem, not a problem. Thank you so much for the training, Barbara. It's been really, really good. Very helpful.
Thank you.
I just wanted to ask one very quick question about expected level of attendance, because my student in year 8, he varies between 80, sometimes as low as 75% attendance. At the moment, he's 90%. And I know there's no one size, one cap fits all. But what would be your ballpark figure of expected levels of attendance for a student suffering from sickle cell?
Well, some of our children have 95, 98% attendance, but going back to your pupil, there's probably other things going on with him, causing him stress or something, but we need to get to the bottom of that and support him as much as possible. It may be, if you look at when he was in year 7, we didn't have the problem, but maybe things have changed a little bit for him. So your supportive sickle cell nurse, you know, get her involved as well, and they can sort of provide support, see what else is going on, and provide support for the child as well as the parent. Yeah, so if a problem shared is a problem halved. So sickle cell nurses are very good at, haematology nurses are very good at talking and getting things out of children and sort of getting to the bottom of the problem and trying to sort it out for them, really. So there's a lot of resources there at Winston for you to tap into.
That's brilliant. Thank you. That's helpful.
You're welcome.
There's a question in the chat which actually I can answer, Barbara. If
Thank you.
I'm Mabtra, one of the haematology consultants. Imperial, I also do an outreach clinic, a paediatric clinic at Hillingdon. And I'd just like to say it's a great presentation, Barbara. And I don't think I've seen this number of attendees at any of our education sessions, so this is just fantastic. Excellent. You know, we hit the over 100 mark, so it's very impressive. Wow. So the question is from Ramona. Are all people with sickle cell at equal risk of stroke, or is it specific types of sickle cell? So it's mainly hemoglobin SS and S beta 0 thalassaemia children that are more at risk, and that forms the basis of the 2CD screening program that's done nationally. Oh gosh, and all my students are deaf. Is there a specific sign for sickle cell in sign language? Barbara, do you know? I don't.
I don't, but we can find out, or we can all help create one, which might be good.
Very briefly from Google, an abnormal red blood cell that has a crescent shape. So I think it's sort of a crescent shape or something along those lines. But yeah, I can find out something a bit more official from that at a later point, and I'll forward that through to you, Ramona.
Have we come to the end of the questions?
Oh, hi, Angela. For the pupil experience, are you able to turn on your camera?
Hello?
Hi, Angela. Yeah, apologies. My Teams is running quite slow at the moment.
Oh, it's okay.
Would you be happy to take some questions about your experiences within schools?
Yes, that's fine.
What would you say has been the things that have helped you deal with your sickle cell within school environments?
I think teachers and safeguarding teams and nurses being aware that I have the condition has been extremely helpful, because having sickle cell is not easy. It's an invisible disease, and although there are many ways to prevent it by avoiding its triggers, it's an unpredictable disease as well. And so one never knows when a crisis might occur. So it could happen in school, so it's important to feel safe at school and to know that I have the support of my teachers and, yeah, nurses.
Excellent. Have you ever had a sickle cell crisis within a school, and how did that feel, and how was that dealt with?
Yes, it's actually happened during an English mock. So I think it was just, I was really stressed and very nervous. So I started feeling pain and I had to leave the hall, and I was treated and brought with an ambulance to the hospital, and I felt really supported by my teachers, and they helped me calm down because I felt really stressed. And yeah, so I've had experiences having pain in school, and it's been okay with the support.
Lovely.
Does anyone have any other questions for Angela?
Winston has his hand up again, I think. Or if it's a legacy hand, I don't know.
Oh, yes, it is. I do apologize. I will lower it right now.
Sorry?
I think it was just a legacy hand up. That's what we've taken to calling the yellow hand being stuck up.
Miss
Okay.
Spencer has a hand up. That sounds like a teacher.
Yeah, it's just a quick question. Basically, we've heard of sickle cell trait and sickle cell anemia. The sickle cell trait, is that the other types of sickle cell that you were talking about that you just said were less in, or is that something completely different when you said there were like about 3 different types of sickle cell?
Do you want me to take that?
Go on, Barbara, you can take that. Yeah.
Okay. Well, the sickle cell trait is the carrier status, that sort of the silent one that doesn't cause any trouble, because the trait or the carrier only has one gene affected. The disease, the children or the adult has both genes affected, right? So, there's that mutation, remember? So you have to have the full-blown disease or the anemia to suffer the problems. If you are a carrier or the trait, it doesn't affect you. Does that make sense?
Yeah, that's fine. Just that on your initial slide, you had about 3 different types of sickle cell. So those are all sort of forms of anemia. Is that correct?
Okay, the list so all of the list of the sickle cell sort of anemias, they've got to have S and something else with it, remember? So so those are the full-blown. I didn't talk much about being a carrier or having the trait. I talked about sort of inheritance implication. Let me go. Yeah, inheritance implications. Remember that, the inheritance?
Yeah, no, I was clear on that. I was just wondering about the other ones where you had like the SS and then you had different types. So those are all the full-blown forms.
Yes,
Yeah,
all
and
of
they
them.
will, yeah. And then the ones that tend to be severe are the hemoglobin SS. Oh, I'm going back to an S beta naught, and the others tend to be classed as milder phenotypes, but that's not always the case.
Okay, thank you.
Thanks, Mark.
Florence is next.
Yeah.
By the way, thank you, Angela, if you're still there.
Thanks, Angela. Florence, you may need to unmute.
Hello, can you hear me? Yeah, can you hear me now?
Yes.
Yeah, oh, okay. I'm a teacher and I'm a sickle, I'm SS. And you mentioned in the slide waiting 30 to 40 minutes before contacting parents or extra help seeking. Is that before administering paracetamol or after?
After, if they don't.
So how long do you wait in between?
Well, what you just sort of, this is for sort of mild, what we call mild to moderate pain, if they're feeling a bit of discomfort. This is not for anything, you know, sort of majorly worrying. So if sometimes they can have a bit of arm pain or something like that and then get a bit grumpy, then usually they'd probably approach you and say, can I have some of my ibuprofen or paracetamol or whatever? And then you give them that and sort of just keep an eye on them for about 20 to 40 minutes, because the medication's got to work, hasn't it? It's got to get through the system. If after, say, 40 minutes that they haven't improved, then, you know, it might be good to let the parents know that, you know, you've had to give medicines today and little Mary's not getting any better, you know, but we don't automatically send them home. It'd be good to distract them. One of the slides sort of talks about distraction. If they're feeling well enough to sort of move about, sort of distract them with things. You know, let them be the library monitor for an hour or two or something, just to, so, you know, to distract them.
Okay, so in terms of, is it worth asking them in terms of the level of their pain threshold before then administering it, or is it just a case of?
I think they will approach you.
Okay.
Yeah, so I don't think they'll seek you out unless they need a bit of painkillers.
Yeah. It's just that sometimes, you know, when sometimes like some water or just keeping the body warm and things like that could be the answer before administering the pain relief. And so at what point do you gauge when you need to administer it?
You see, the thing is, you've got to be guided by the child who is a regular pain sufferer, put it like that. So they will sort of approach you when they need to, but they wouldn't seek you out really if it was something they were used to. I think, you know, you can say to them, sort of, what do you normally have? You know, parents would have bought in the paracetamol for them anyway, or the ibuprofen. They'll just tell you, I have 1 tablet of ibuprofen or some, you know, medication, because the parents would have had that conversation with you. The medication needs to be prescribed, so you can't give anything that's a stock. You'd have to be prescribed, and then the doctors know exactly how much medication that child needs. That's why we have to have the prescription label on the bottle or the tablet box. So, you know, it's okay for them to ask for pain relief if they need it. But as I say, it will be on the prescription 6 to 8 hourly, so they're not to get anything between that.
Yeah.
And if they're feeling really groggy and ill after the 40 minutes, say, and, you know, and they just want to go home, that's when you'd sort of speak to parents and see what they think.
Yeah.
So,
all right, great.
Is that clear? Is that clear?
Yeah, that's fine. Yeah,
fantastic. Thank you.
Thanks. Are there any other questions at all for Angela or Barbara?
I've got one for Angela.
Go for it.
Angela, what was it like when you were doing PE? Because I have a lot of children sort of complain about, oh, I feel tired, and they don't think I'm tired and things like that. Did you experience anything like that in school?
Yes, actually. PE wasn't the best subject for me because I often feel tired and I get fatigued really easily. So every time I had to tell my teachers I wasn't feeling well, or I had to bring notes every time. And then I always felt like maybe my teachers thought I was lazy, or I just didn't want to do the PE, when in fact I actually do love and I really enjoy sports. And some activities I can be able to do better than others. But I once had a teacher that, rather than making me sit on the side and watch the others doing PE, she found creative ways to get me involved, and so I really appreciated it. Yeah.
Excellent. That you know, that shares, because we do have a lot of, you know, sort of children bringing that up, and they do love PE. They want to be the same as everybody else, and they are, but we just have to be more inventive around it, just as you've just said, Angela. You know, my lovely PE teachers out there, you know, just a bit more inventive around PE and games and tiredness for sickle children would be really good. Yeah, so thank you for sharing that, Angela.
It's okay.
So Annalise Boateng has put in the chat, hi, I'm a PE teacher, and my experience is that one of our sickle cell students suffers from cold and usually needs to take an extra jacket when taking part in lessons. Are there any other questions for either Angela, Mamta, or Barbara? So if not, I just have to say thank you so much, Angela, for sharing your experiences, and also Barbara for giving the presentation today, in particular for covering for Jackie as well. That was a Herculean effort on your part, and thank you so much for your time. And thank you everyone for making the time to join the session today.
Thank you very much, everyone. Thank you. Great to have the opportunity.
Thanks, Barbara. Thanks, everyone, for joining.
Bye-bye.
Thanks, Ralph, for organising.
Bye.
Well done. Take care, everybody.
Bye-bye.
Thank you.
Thank you.